So there's a whole raft of phase 3 trials that will come mature, SD101, CMP, 001, the Master Key 265, and then there's the Nectar-Nevo trial. So Jason, a lot of buzz about these IL-2-like compounds. There's ALKS4230, which is a genetically modified IL-2. There's NKTR214, which is a pegylated IL-2. And I guess the idea was it would not bind to the alpha receptor of IL-2, so it wouldn't promote Tregs, and it would activate T cells. So what's your read on the NKTR214 Nevo trial? That's a phase 3 trial.
Sure. So, the predicate here being that before we had all of these drugs we've just been discussing was that a high-dose IL-2 was a therapy that was available to some patients and was associated with a long-term benefit. That's really fallen away due to the toxicity, but we still all acknowledge the fact that some patients were cured. And so as you're suggesting these novel approaches to harness IL-2 biology and then bring it into the checkpoint inhibitor space. So Nectar-214 is a pegylated molecule that tries to sort of take the parts of the IL-2 molecule that we think are the important ones. I don't know that we have to get into all the details, but then to try to use that in combination with checkpoint blockade to enhance that. And I think that the early data set is very interesting in that regard. The clinical data showed that in some patients with advanced melanoma in the frontline setting, there were complete responders in patients who were PD-L1 negative, and that was thought to be pretty unlikely. And there were changes on a translational level in terms of number of immune cells going into tumors and the immune changes in a tumor that you would think would associate with immune response. All of that trended in the direction that you would expect, enough that this phase 3 trial has been launched. I think it's worth noting in the context of our prior conversation about refractory disease, the trial was launched in the frontline setting, and so it won't necessarily help us with that second line question. And we'll have to see. And so that really the question sort of becomes, can you kind of add gas to the fire? I think that's what people are thinking about with this. Can you supercharge PD-1 so that it works even better? And I think we're all hopeful. I think we all have to be cautious, however, given our overexuberance perhaps about our most recent phase 3 trial, which failed in this space. And did we learn adequately the lessons regarding how much data we really need to generate to feel confident about a phase 3 result? I think that's still an open question. So this is a trial that I very much hope is positive, but I think we're going to have to wait and see.
I hope at next ASCO or next ESMO we're going to get some answers. I just hope we're going to see positive studies. Okay, so the other interesting phase 3 trial is with ipilimumab, and I was a bit surprised to see that, Vern, there was an ipilimumab versus ipilimumab plus, I think it's tilsatolimod, which is yet another TLR-type agonist. That's already gone to phase 3, and were you surprised to see that it went to phase 3, never having stopped really at phase 2 in the middle? It was sort of phase 1 right to phase 3.
There's still a lot we don't know about how the best develop these drugs. We have so many combinations, so many choices. I personally would love to see us develop some of these compounds in the neoadjuvant setting, because we can really understand by before and after tumor samples whether the drugs are achieving the desired effect, rather than wait for a 700-page patient phase 3 trial to tell us it had no effect. But the pressure's on. There's so many different compounds and so many different companies that, yes, there's a push to push a lot of these directly into phase 3 trials. And for all the focus that has been on combining with anti-PD-1, I do think it's important to recognize that IPI, with its toxicity and its disadvantages, we need to do better with that one too. It's still a very important part of treatment. So there's nothing inherent about any of these immunologic combinations virtually that's specific to this. Will only help an anti-PD-1 agent be more effective. It won't help an anti-CTLA-4 agent be more effective.
Are you implying that ipilimumab is a victim of the Rodney Dangerfield effect? I mean, it just doesn't get any respect. I mean, is that what you're trying to say?
That may be the case, yes. Okay. It doesn't get a lot of respect.
I actually do like the fact that this study has a control arm as IPI in this setting, right, in the second line setting. Because IPI we know is a drug that can still cure 22% of our patients, and actually is the appropriate comparator from my perspective in the second line setting.